This week on the BackTable podcast.
When you do the first of anything, whether it's first in your hospital, first in the region, first in the country, first in the world, it doesn't matter. If you're doing the first in the hospital, it's a big deal. How did you get over the fear or the anxiety or the whatever? How did you get the guts to do it? And I always answer that question one simple way. You have to remember one thing. It's always the patient taking the risk, not you.
Mm-hmm. Totally.
And as long as you're focusing on doing the best thing for that patient and giving them an alternative to whatever the status quo is, and there's that rationale and the patient knows, you're good. And so that was the idea. I mean, it was all driven by making things better for the patient.
Now, a quick word from our sponsor.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode.
My name is Andrew Niekamp. I'm an interventional radiologist, and today I'm joined by somebody who needs no introduction, but I'll attempt to. This is Dr. Barry Katzen, the Chief Medical Executive Emeritus at Miami Cardiac Vascular Institute, one of the men who trained me when I was going through my fellowship. And so I'm very excited and very honored to be able to be here and talk to him today about the history of IR. So Dr. Katzen, welcome to BackTable.
Thank you very much, Andy. It's a pleasure to be here, and I'm looking forward to the conversation.
You and I have had a lot of conversations over the years going back, but I think it's really great that we're going to be able to now have this conversation and everybody else is going to be able to hear it. I know it's definitely changed the course of my career. So kind of how I wanted to start this was just asking you, you were there for the advent of this entire specialty that is now a primary specialty in medicine in the United States and is rapidly growing and is considered to be one of the most innovative specialties. So I guess what I really want to ask you is, what kind of drew you to this direction in the first place? What did you see the potential in this area? Clearly you saw something and ran with it. I just want to ask you, what were really the roots and what really got you into it?
Yeah, that's a great question. And of course, when I was training, there was no interventional radiology. Just to sort of lay a little bit of context, if you can imagine a world with no cross-sectional imaging, no CT, no ultrasound, just pretty much X-ray and angiography for us to work with as a diagnostic point of view. Angiography was really had a very important place in how we diagnosed tumor, atherosclerosis at the time, and other types of things. But so catheterization was really kind of the basis of it was called angiography at that time. There were a few fellowships or additional training, but the training programs in those days were called cardiovascular radiology is what you would do. And we would use angiography to determine what kind of tumor a person had, whether they had cancer of the pancreas, whether a mass in the kidney was benign or malignant. And so the angio architecture of various types of pathologies was really the hallmark of how we diagnose things. As a resident, seeing what was going on, I began reading literature in Europe, where in Scandinavia and in Northern Europe, people were starting to use angiography, not so much angiography, but use X-ray to guide needles into places. And so to take one of the first things I learned how to do, which was needle biopsies back then, in the United States, the oncologic surgeons, the conventional wisdom was that needle biopsies, image-guided needle biopsies, were a bad thing because of something called needle tracking. That if you put a needle in a tumor and you took the needle out, you were just going to track cancer all over the place. And so that was kind of the prevailing wisdom when I was a resident at Cornell. And I was reading in the literature all this work being done from in Sweden and Norway and Northern Europe. And so I ultimately worked out a way when I was a resident to go to the UK, where a lot of this was being done, to learn what you would call now chest intervention. So the idea of image-guided therapy for diagnosis or image-guided diagnosis to improve our diagnostic ability is kind of where we went. And so in those early days, the concept of, well, now we can see it, we can get something in it, whether into the circulation or into the needle, how can we treat it, is really what started turning on a lot of the pioneers of the time. Dotter in 1963 had published his what is now a landmark article about angioplasty, but in that article, he postulated using the catheter as a surgical instrument. In the 70s, when I was a resident, that really resonated with me. And as I was training, I started thinking in those terms. And there were other pioneers at the time when I was a resident, Stanley Baum in Boston and others, who were beginning to use the catheter as a surgical instrument. But also the concept of image-guided therapy was really broader than the catheter, because people were using needles to get various places in Europe. And so that's kind of how I got started. And I have to say, when I finished my residency, I decided to take an additional year in angiography. And the chairman of my department at the time advised me that I was making the biggest mistake of my life, because angiography was going to be dead. CT scanning was just coming around. And of course, the big prediction of CAT scanning, and at the time you couldn't do CAT scanning in the abdomen. In the beginning of CT scanning, it was only in the head, but we could see where it was going. And so the prediction was it was going to displace angiography. And so he advised me that I was making a big mistake. And I told him, I said, look, I'm not really interested in angiography for diagnosis. I kind of agree. But I think it's going to be a totally different field as we start treatment. And I was really more interested in the therapeutic aspect and therapeutic potential at the time. And so that's kind of where my career got started. It wasn't to go into something. It was really to kind of change the status quo. And the whole concept of that I think drives interventional radiologists and what differentiates us from other disciplines who might do the same procedures is that we're driven by change and how we can improve the status quo. That fundamental characteristics of IR, it's all about change and how we can improve. We're always looking for things that we can make better, less invasive. And that was kind of how I viewed the world at the beginning of my career.
Yeah, I think you hit on a really great point there. I mean, nothing drives me more crazy than complacency. It really is, I think, the Achilles heel of medicine. I think one of the most dangerous things in medicine is this, the classic, we've always done it this way, right? That's honestly what drew me to IR too, was the innovation, constantly looking for ways to improve, never being complacent. And that's what I really loved about the specialty. And I'm glad that you brought that point up, because I think that's really important, especially in today's days. It's very easy in medicine now to become jaded and complacent.
And I think fundamentally we have to swim upstream because we're having to change. And I think one of the things we've always tried to teach our fellows is how to manage that swimming upstream and how to manage change and how to avoid frustration and not be combative about it. There's a process of how you can actually be successful in executing change, because during those early years, when we were, getting involved with stopping bleeding and using catheters to stop hemorrhage, or, embolization was one of the early, applications, let's say, in what became IR. Nobody was really objecting. It was actually good because we were keeping surgeons sleeping at night. We became the managers of hypertension. We were the ones coming in at night in those early years. And so we were very well received by the people who were treating the patients with the alternatives, whatever the alternative or status quo was. But then as we started to look at vascular applications in the broader sense in atherosclerosis, things got a little bit more complicated in terms of executing change.
Good, to say the least. Absolutely. So you started your career in New York, then you went to the DC area, Northern Virginia, and then you started there, and then you decided to come down to Miami and found the Miami Cardiac Vascular Institute at the time, MVI. But how did you come up with the vision to create MCVI, and what was your long-term goal? What was your short-term goals? How did you see the future that you really built? At the time, it was beyond luminary. It was, really visionary. So how did you really develop that up in New York and DC before you came down to Miami?
I just want to go through a couple of things and how I wound up in Virginia. Yeah. So those early years that we just talked about, they were exciting years when I was at St. Vincent's, which doesn't exist right now. And a couple of important things. One is I always was a very collaborative person, very clinically oriented, always worked very closely with colleagues, including surgeons. I, early in my career, went to Europe to do what would be called a mini fellowship in Rome. That fellowship, which was way back when in 74, provided me with a lot of opportunity. One is sort of mandated by the people who hired me. They wanted me to be trained by a mentor who had been at St. Vincent's for 14 years, a person named Plinio Rossi, who is considered one of the pioneers of early advanced angiography, when the J-wire and the floppy wire were big advances, to how we got from point A to point B. Shaping of catheters, the different various shapes that we're developing as those early years of angiography were being developed. He was one of those pioneers and considered a master technician. So I took a job directly out of residency where I would be a fellow for a year and then become chief of the section after year one. But the proviso was I had to train with the person who had been the chief of the section. And there's a lot of deep background about that. But the bottom line is I wound up in Rome in about September of that year and spent 3 months in Rome. And I did my first angioplasty in that year. I did it together with Plinio. It was done in 1974, actually, before there were balloons. It was an iliac angioplasty. But being in Europe in that time gave me the opportunity to meet Grunzig. He was a young person who was also developing new ideas, and meet a lot of the other people in Europe, which is kind of where all the action was, if you can imagine, through the various places in Germany and Italy and Austria, and as we began having meetings across Europe. So I became exposed to this group of young people that were just out there exploring and trying to break eggshells and create new solutions to things. So my whole life changed, to be perfectly honest, in terms of what I thought was possible and what I got some clarity of vision for myself. And so the whole idea that I mentioned earlier that we talked about of image-guided therapy or transforming medicine by doing things less invasively, that those basic fundamental concepts were really embryologically developing for me while I was in Europe. And so we did a lot of firsts there, and I met a lot of people. And when I came back to New York, I was really a changed person. And in fact, the people I worked with at St. Vincent's remarked about how things were totally different. And so I really was driven to this whole change and looking at every patient as a problem that can be solved differently. And how can we help this patient as we got to see things. Now, the other thing I should mention is that I was trained at a time where radiologists did the cardiac caths. So when I was at New York Hospital, I was fully trained in cardiac caths. I did a lot of caths. Of course, there was no treatment involved. You were just doing diagnostic work at the time. And when I moved to St. Vincent's, I was co-director of the cath lab along with a cardiologist because of that. And I built actually an outpatient cath lab practice from New Jersey. And I began the process of clinical practice at that time. And to just introduce that, I know it's not the focus of your question here, but I think it's relevant. At the time, it struck me that radiologists and what we were doing invasively, we were the only specialty that was not providing the care for the patients that we were doing procedures on. Interventional endoscopy was developing other types of invasive procedures and surgery, and struck me as wrong. And so I started, and that's how I built my first practice, to be perfectly honest, was I was doing caths and people would call me because St. Vincent's had a referral basis from New Jersey. And I said, yeah, just give me the patient's number. I'll call, we'll set everything up and we'll do their cath. And so that's kind of how that process got kind of going, and always saw every patient. It was just the way I practiced and the way I thought it ought to be practiced. So I wound up moving to Virginia to join a group of, it was not an academic physician, joined a group of colleagues from Cornell who had moved down to this practice. And they called me. I said, look, I'm into something very different than when we were residents together. Things are really changing. And they said, okay, that sounds good. And I said, really, I'm interested in doing this full time. They said, well, if you can develop the practice to do it full time, that's fine. We'll support you or whatever. And at the same time, I had what I thought was the best job in the country because we were doing everything. We were publishing, but I was the hardest working guy in the department, like most interventionalists today are. I was doing all this stuff, working at night. as emergencies, because now we were treating, I did the first lysis cases. This is back in 74. There wasn't even lytic. You couldn't get lytics. You couldn't buy lytics. How we started lytic therapy is a whole other issue. But I was doing, cold legs, GI bleeding, internal bleeding, traumatic bleeding, all this sort of stuff as we were transitioning to become current managers of emergency cardiovascular events. And my chairman was very unsympathetic. I needed a place to live close to the hospital. I was commuting from New Jersey. And I said, look, I summoned up the courage to ask for a raise, which for me was a very difficult thing. And I got the answer, I can't talk about that now. There are too many other problems, blah, blah, blah. At the time, I was winning medals at the RSNA. And next time you come by, there's actually an exhibit. I was showing one of the fellows on embolization that we won a gold medal for at the RSNA, this kind of work that was being done that was all pioneering. And nobody really kind of appreciated it. They called me. It was an opportunity. So I decided to leave because I couldn't get a place close to work. So I moved, and the group was very supported. I started doing half-time, wasn't called interventional radiology yet, half-time specials, invasive, whatever you want to call it, interventional work. And it rapidly grew to be full-time. I had surgeons who supported me. And over the next 12 years, I developed one of the largest teaching programs. We had a fellowship program. We trained 11 or 12 fellows during that period of time, and became one of the largest vascular programs in the United States, along with 2 or 3 others, which were also being done primarily in private practice at the time, because universities were really opposing the development of this through chiefs of surgery and the conflicts that were going on. And so to get to your question, how I decided to move to Miami and start all over again, which would have been my third practice, basically, I had what most people in the United States at the time thought was like nirvana. It was a huge practice in private practice. I had academic. I was a consultant to the NIH, to GW faculty, everything that was going on in Washington, D.C. at the time. But what happened was, during that time, turf wars had developed and were developing. And I was always interested in the future of our specialty. And so we had a situation where interventional radiology was developing peripheral angioplasty, renal angioplasty, thrombolytic therapy, all this sort of stuff. I was advocating for clinical practice, which was not being adopted by most interventional radiologists. And so I started thinking about 2 things. One was what became sort of a disruptive technology. Clayton Christensen had written this book probably around late in those years. But I could see a collision course developing now, because we had a situation where the surgeons were taking care of peripheral vascular disease. The hypertensionologists were taking care of renovascular disease, which was a big thing at the time. The cardiologists were taking care of cardiovascular disease. And all these things were going to be converging around angioplasty. That angioplasty was going to be this disruptive technology that was going to cross all these multidisciplinary grounds and really cause a collision of specialists. And that was on the one hand. On the other hand, when you look at vascular disease and cardiovascular disease, it's the same disease, and it wasn't being treated that way at the time. It was being treated as cardiac disease, peripheral vascular disease, renovascular disease, hypertension, cerebrovascular disease. And you had all these people that were treating kind of the same thing, but in different silos. And so I really started thinking about patient-centered care, if you would call it, and that we were really organized in the wrong way for treating this disease. So you had the problem of interventional radiologists and specialists that were developing now that wanted to take away things from interventional radiology. And so one question was, okay, how's IR going to survive? And it really troubled me. I could see what was going on around the country. And so the concept of patient-centered care and creating a new model in which radiology was involved from the start, because we were still young and driving things at that time, a new model of care separate from the traditional medical staffs, where everything was organized into silos around medicine, surgery, radiology, and so on, is kind of what developed. And so during my final years in Washington, this concept of building this cardiovascular institute or center really started to develop. And I started approaching the places in Washington. I was practicing at a small hospital, Alexandria Hospital, which at that time, basically, we were attracting physicians from all over the world. I was doing tutorials. I was training patients once a month. We were doing live case courses. And we had a waiting list of 10 or 11 months, to get people in. I was evangelical about trying to train radiologists at the time, but anybody, and how to do this. I felt we couldn't wait for developing residency programs. This is something everybody who's out in the field needed to learn. And I was really passionate about that and got all the academicians from around the country to come to Alexandria. So Alexandria became the center. Charles Dotter actually was sending me notes. He was very proud of the work that was going on in terms of dissemination, because more or less his failure to advance the technology during the first decade afterwards. But I was frustrated because we couldn't do it without cardiology at Alexandria. And so I went to some of the other big programs in town. In Washington at the time was the Washington Hospital Center and Northern Virginia, Fairfax Hospital. And both of the folks there were really, really interested and would have pulled the trigger to do it. But, I was in private practice. I was in a group of 5 or 6 or 7 people. And the idea of leaving my group to join a competitive group in the same city was just this kind of ethical barrier that was a barrier for me for doing it in the same town. About the same time, people from Baptist Hospital, which you're familiar with. So I used to run these tutorials in Alexandria, but I also ran a very large meeting, which was in Washington, D.C., that was really much broader. And, it was a larger, more conventional didactic meeting on sort of future of radiology, broader. And the group from Baptist actually approached me and asked if I would come down. Actually, they didn't ask, they asked me, but they said, look, we're looking for a senior level interventionalist. We want to start an interventional program. We see that as a very important direction. And to their credit, they saw what was going on. They had people doing angiography, but they really wanted to make the leap. So I gave them the names, actually, of several colleagues and people, to join. I came back. And since it was where we were from, I talked to my wife about it and ultimately called them a few weeks later and said, look, I've got these ideas, all right? I'm not interested in just, making a lateral move, but I have these ideas. And if the group in the hospital were interested in it, that I would pursue it. And I wrote a 3-page white paper that described what you would call the Institute. It was a description of the Institute. Sent it down there, and they went to the hospital and they went to their group because it involved radiology giving up stuff at the time, because we were going to create a new entity in which everybody participated with a new set of rules and a new set of guidelines, but radiology's position was at the core. And going back to what I was trying to do, radiology was going to have a strong position in it. And the turf battles didn't exist down there. And ultimately they said yes. They sent people up and that's why I moved. It was to create a patient-centered care model where the operation of the Institute was based on the patient with cardiovascular disease. We were going to be committed to less invasive therapy, strategically committed to less invasive therapy first, which is meaning we were going to commit financial resources, and all the decisions were going to be directed towards how we could improve cardiovascular care. And that included a pill or procedures or making surgery less invasive. And we also recognized that turf battles were destructive, and we were going to do everything to eliminate turf battles at the get-go. We were going to face it up front. And that's kind of how that started. And so that's how the Institute was created, and that's why I moved. Now, it morphed a lot, but that's the why.
Of course, yeah. So you touched on a really important point there that I want to kind of dive into. So, being on the younger side of IR and coming in now with this resurgence of the clinical model and everything, I think we're now starting to realize how important that is for patient care. But it sounds like it was developing back in the 70s. You said, radiology had come up with all these procedures, yet was losing the turf war for all intents and purposes. What do you think led to that? I think I know your answer, but I think it's important to actually get it on the record. But what do you think led to it? What did you find? What was your secret sauce in Miami that really tried to eliminate that issue from medicine? What was it about radiology that you think made us lose the procedures in general? Why did these turf bores even come up?
Well, I think, and I wrote several articles about this early on and published in the Journal of the ACR, which is the broader house of radiology. But I think that goes back to Daughter's original statements, and that it means that anybody can learn what a procedure, okay? And if we're technicians, anyone can do what we can do. And if we don't assume the clinical responsibility of taking care of the patients that we're treating, then we're going to be replaced. And that's what Charles said, and that's what I said. And I was preaching this loud and clear to everybody. There were some people that were able to, and then we had to work harder. Look, the reality is, men had to work harder. And you had a generation of radiologists who maybe didn't feel as comfortable. They were several years away from internal medicine, but you had to relearn, you just had to relearn it and dive in, roll up your sleeves. And of course there were limits to what we could do, but we had to be responsible. We had to be the person that gets called when there's a urinary tract obstruction, when the patient can't move their bowels, whatever it was. We had to be the person taking care of the patient. And in fact, in Miami, because I wasn't certain that this was going to work, okay, that this whole grand idea was going to work as it relates to protection of radiology, I felt that we could never count on others to protect us as radiologists. And the whole idea of clinical practice is that if everything fell apart, okay, and we got left in a world of terrible turf wars, that we would be left with our clinical practice and we would compete. And I said, all right, the worst case scenario is we would be clinicians and we would be competing for patients like everybody else. And so that was my doomsday scenario, if you would. And I think to a large extent, that still is the case. So I think that, I think if you want to be a technician, and there was a lot of controversy during those years about whether we should train surgeons, whether we should train anybody else. We had people, coming to ICET, cardiologists and others who would come and use the fact that they were at ICET to look for privileges in uterine fibroid embolization, and apply to things. And it's like, you can't rely on artificial barriers to kind of protect turf. I just felt that was not right. And that drove the clinical impetus. And there were others, I have to, give credit, Bob White at Hopkins felt very strongly about this. He came to Alexandria many times, also wrote about it. So there were some academicians at the time who really, really bought into it. Bob had been a cardiologist and an internist, and not many, not enough.
And so in Miami, you were able to develop you seemed to develop a very in-line vision with what you had. And coming from there, I know that, the turf wars are basically non-existent. What was the secret sauce at Miami that really did make it work?
Well, I think there's a couple of things. One is that the concept of self, okay, is really very important. If you don't look at yourself as a clinician and act like a clinician, no one else is going to. Okay, so that's
very true. True.
That's like the beginning of it, all right?
Yep.
And so you have to live and act that way. And so when I first moved to Miami, and I apologize to the person who's involved here, but I decided not to move with my fellow. I mean, the fellow that had been accepted. And I decided I had to do every case myself, talk to every patient myself, talk to every doctor, because it was important about how people looked at you, okay? And if you want to change the way radiologists are viewed, you have to be that instrument of change. And so that's the way it was. I saw every patient. Actually, the first thing I did when I moved to Miami was I eliminated the ability to order anything we did. You couldn't write an order. You had to write an order for an IR consult. And people reacted to that in a negative way, and I defended it, but you had to deliver on it, meaning you had to go see every patient, whether it was for a minor procedure or a big procedure. And the rationale, of course, for that is that, you can't order an appendectomy, you can't order a cardiac cath, and you can't order a pulmonary angiogram. It was very rational. We're the ones who have to, the reason for that is that the interventionalist, the person who's going to do the procedure, is the one who is responsible for the final decision on whether that procedure is necessary, whether it's the best procedure, whether it's the right procedure in the right place, all those kind of things. So we went about really changing the way people viewed what an interventional radiologist was. And we started delivering on that. And when the fellows came, as you know from your own experience, being a fellow in our institution is really hard because of the clinical work that's added to all the procedural work, but we had to deliver on that. So I wrote a paper, was published in the Time of Radiology because we didn't have JVIR then, on how the interventional radiologist should be an equal partner, considered an equal partner in the delivery of care for our patients. You have to be prepared to do the work. So that's kind of how. Now, in terms of turf, nothing lasts forever, okay? At the time, the lack of turf battles there was really a function of the timing. Nobody was really as interested in this, and there were some arbitrary things that were set in place that allowed us to get started. There wasn't any turf battles, but one of my, as you probably know, I generally live about 5 years out in front of everybody, and that's where my brain generally is. And so you can't rely on things to stay permanent. And so you have to be always thinking about how things might change. So we may not have had turf battles, but we were always prepared for being competitive if we needed to be competitive, which is more like the environment is now, actually, today's world.
Yeah, absolutely. And by being prepared, you just mean good clinical acumen, making sure that you're absolutely dedicated to the patient.
Yeah, and but more important than that, you have to be the recipient of referrals. The important thing is that people have to call you and say, Dr. Niekamp, Dr. X, can you see this patient? Will you see this patient? The fundamental practice of making it easy for patients to see you by saying to the doctor, yeah, give me the patient's number, I'll give them a call. You have this problem, whether you're in the reading room, whether somebody's calling you, casually, whatever, you have to make it very easy for people to send a patient to you, because otherwise it's very hard.
Right.
That's
right.
We had competitive issues over the time, competitive procedures. Don't forget, we talked about IR and change. We've lived in 4 decades of dramatic change in how patients are treated. IRs are basically the tip of the spears in very many cases about that change. So you just have to make it easier. You have to be an equal partner. You have to be a clinician that's able to accept patients. Okay, you want to be a clinician? How do I send a patient to you? Where are you going to see the patient? What I tell fellows now in terms of building a clinical practice is in the office, okay? It's seeing patients when you're not doing procedures. And you're not going to be successful in clinical practice unless you're seeing patients in the office that you're not treating, okay? And you have to be able to provide longitudinal care, and both after procedures and for patients. You have to be able to be involved in disease management. As an interventional radiologist, you're a proceduralist primarily. Everybody else practices medicine in disease management mode, okay? And so how do you marry a proceduralist with disease management? And so you have to be willing to practice longitudinal care in the diseases in which you as an interventional radiology participate. So in the vascular case, you have to be able to follow aneurysm patients longitudinally, asymptomatic carotids, medical management of claudication, things like that, following those patients and being the key decision maker when or if patients need to be treated. And by the way, the same thing in oncology and interventional oncology and other areas, vasculitis, other areas that we might touch. Somehow you have to marry the disease management into the procedural aspects of what we do.
Yeah, absolutely. Totally. Just 2 more questions for you here, and then we'll let you go. But one thing that's always been fascinating to me, and just hearing stories here and there, is the early days, the invention, the growth, really the birth of the specialty. If you could just talk about those early days with you, Jim Beninati, Gary Becker, Mike Dake, all together. I mean, the environment, the creativity. Can you just kind of talk to that? I think it's a really fascinating story.
In terms of creativity, okay, there's 2 aspects. One is creating new solutions, and the other is creating new devices, and how you marry them, okay? So fundamentally, we are a group of people, and all the people that were involved in the birth of our specialty were a group of people that were looking for new solutions, okay? We knew that you could guide, the concept of image-guided therapy is that if we can see inside the body, How can we do something about it? And that's the big idea, right? And so we worked with industry who were making the devices, to try and create solutions. Sometimes we made our own. My brother, who was a general radiologist, engineered his own compression device, and had an engineer in the lab make some sort of a thing where you could crank down and do manual compression, and so that's the kind of way it was. And by the way, when I began my career, we made our own catheters. The beginning of angiography was the angiography labs had all the tubing, had the hubs, and we would make and shape catheters ourselves. So we came from that background. And that's
Right.
why people had names on catheters and things like that, on shapes and whatever. So we were a group of people looking for solutions, but without kind of the right devices.
Right.
And that drove industry. And by the way, I view interventional radiology as the foundational beginnings of all less invasive therapy. We are the beginning of image-guided less invasive therapy. Many of the laparoscopic device people came out of the IR device companies, the early IR device companies, and so on. So that concept really was based on the foundation of IR. So during those days, every patient, everything, every single patient. And I think nowadays it's more in a research concept where you're looking for every patient, can they be included in a research trial? And that's the way it's done. But in those days, prior to the Palmas stent, there was really no regulatory driven, clinical trials. The
Sure.
Palmas stent was the first one. So when Mike was around, when everybody was around at MCVI, every single patient was, how are we going to solve this?
Yeah.
And if we had to make or create our own, there was no real regulatory environment. And so frequently people said, when you do the first of anything, whether it's first in your hospital, first in the region, first in the country, first in the world, it doesn't matter. If you're doing the first in the hospital, it's a big deal. How did you get over the fear or the anxiety or the whatever? How did you get the guts to do it? And I always answer that question one simple way. You have to remember one thing. It's always the patient taking the risk, not you. And
Totally.
as long
Great point.
long as you're focusing on doing the best thing for that patient and giving them an alternative to whatever the status quo is, and there's that rationale and the patient knows, you're good. And so that was the idea. It was all driven by making things better for the patient. It was exciting times. You're right.
Absolutely.
And
Yeah.
and by the way, just going back to one thing, in the early days, this preceding Mike and Jim, even there was a lot of controversy over what we should be called.
Interesting.
Yeah,
Yeah.
no, this is a
Yeah.
little known kind of story, but
Yeah.
there were a lot of people who wanted to break away from radiology, who thought we could never, since radiology, I'm being one of them, how we can convey what we do when we have radiology attached to our name. We were so typecast about being in dark rooms and wearing goggles and all that sort of stuff, and we felt we should be surgeons. We're just as Daughter did, these are just surgical instruments we're using in a different way. And so one of the things that we considered was, should we be endosurgeons? This was one of the topics, should we be the field of endosurgery? And you could have endovascular, endobiliary, endourological, endo whatever. Obviously, there were strong forces keeping us tied to radiology because of imaging, and how disruptive could we be? We were basically a bunch of rogue people to many people in traditional radiology. But there were a lot of alternatives that were considered prior to what we ultimately became, which were interventional radiologists. And now it's a different story.
Yeah. Unfortunately, that is very much still present, as you know.
Yeah, we did have a window of opportunity.
Yeah. It's funny whenever people ever ask me what I do, I'm interventional radiologist, and then immediately it's, oh yeah, I know. And somebody who's a radiologist reads MRs, and just lack of understanding.
When my goal was, when I moved to Miami, my goal with our CEO, when we were talking about what we were doing, because he could never really quite figure it out, I said, well, you are going to be the first CEO to be able to say interventional radiology
Yeah.
and know what it is. All right.
Yeah, exactly. Exactly. Yeah. So my last question, and I think this kind of ties everything neatly. I am huge into history. I think, you'll never be able to proceed forward unless you understand the past. Coming from all of the wisdom that you have, the birth of the specialty, moving from academia to private practice, basically into publishing, and then moving honestly into, now that you've had your time in hospital administration, you have all of this advice, all of these young physicians. It's very easy, like you said, to fall into the path of least resistance, become light IR, read on the side, go home at 4. That's easy. But as we've talked about, that'll lead to relegation of turf wars and acquiescence of the entire specialty. So for those who are listening to the podcast that are really driven by clinical practice, want to grow something in today's environment, you having all the experience now with the birth of the specialty and being involved with hospital administration, working with other specialties, what would your advice be to those interventional radiologists today who may find themselves in what they see as an insurmountable task of trying to build a practice, things like that? What advice would you give them, and how would you kind of direct them to achieve that?
Well, I think that's a fantastic question. And I think it's important to understand that we're in very different times than we were then. And people know what interventional radiology is, which is good, actually. I mean, that's great. Yeah. You cannot have a successful hospital anyway without interventional radiology. And now there are many more opportunities in the ambulatory space to practice interventional radiology and to create your own way. Mm-hmm. So I would say the most important thing is, if you're committed to IR and that's what you do and that's what you enjoy, is to don't settle for less. You may be in the wrong position. I think I talked about swimming upstream earlier. And one of our characteristics that's different, most other specialties are pretty well typecast, and they you can put walls around them, you can put definition around them. Interventional radiologists have much more opportunity because we cover the scope of medicine. You may be trained one way in one organ system, whatever, but go someplace where you can use that creativity in a different way, in a different place, depending on local assets, let's say, whatever they are. Sure. So I think we can deploy our skills in a lot of different ways. So one thing is, I would say, keep an open mind about those kind of opportunities, because we're not done creating, we're not done changing healthcare. This is what we're about, the things that drive us. And I think you have to be willing not to accept failure. You have to, it's not that failure won't occur. Listen, I mean, I failed many times. I mean, life isn't all about success. You have to learn from failure, but you have to be driven by what you really want to do, and it has to be important to you. So, I mean, lots of times it's very difficult. There's family, there's practical aspects of, making a living and so on. But when you look at what interventional radiology is today and how important it is to the practice of medicine, you have to find the right place, the place that'll allow creativity. What we have to do is prevent ourselves from getting bored and accepting the ordinary, and the routine, because still interventional radiologists are driven by change and improving healthcare and changing the status quo. We're still about how do we make whatever the status quo is better by making it less invasive and creating solutions that don't exist. That's still the fundamental in our core.
Could not agree more. Well, Dr. Katzen, I want to sincerely thank you for your time. I also want to thank BackTable for the opportunity to be here today. Really hope that everybody listening takes away some really valuable insights and can take these forward and continue spreading the field of interventional radiology. So again, Dr. Katzen, thank you so much for your time.
Thank you. My great pleasure, Andrew. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe and follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, or Blue Sky. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again. See you next time.